Hello, everyone. I would like to thank the committee and SAGES for the invitation to allow me to present. So this is a controversial topic, nothing to disclose. So going through the papers about to prepare this talk, I ran into this paper done by Dr. Fisichella, who is a friend of mine. And you can see the evolution of Nissen funduplication and other funduplications. So you can see we have 60 years history of Nissen funduplication. I was happy to work, I have the honor to work with Dr. Donahue, that he designed the floppy Nissen in the 70s, and then Dr. Delamagne performed the first laparoscopic Nissen in 92. So some surgeons, the choice of funduplication is mostly dictated by the results of the pre-op testing, as we saw before. But for other surgeons, a tailored approach is no longer used, even in patients with dysmotility disorders. But of course, we know that from previous papers, the recurrence of reflux in the Toupet group made more surgeons to do Nissens than Toupet. These are some classical concepts that we learned during residency fellowship. So Nissen has a much better reflux control, but also has more mechanical complications and recurrences. The symptoms of gas bloating dysphasia are more with Nissen because the valve is more stiff, it's not as physiological like the Toupet. And also that the patients who have abnormal motility or dysmotility or weak motility should go always a partial wrap. But also we also found a paper saying that the Toupet funduplication is favored because it's more physiological and allowing more venting, and so all these post-op symptoms are much less. This paper was published by the group of Dr. Hunter in 2000, where we know saying that the Nissen funduplication is much better than the Toupet at 1 year in controlling heartburn. And in patients with impaired motility, the operation should be done is a Nissen, and even with impaired motility, the dysphagia will not be worse if you do a Nissen funduplication. And there's other papers that support the same concepts from Dr. Patti in the 90s, 2000s, that the Toupet has higher recurrence of reflux, higher failure in patients with severe reflux or severe esophagitis. And of course, in patients with complicated esophagitis, the Toupet has a higher failure rate. What is important for surgeons is to address different stuff. What is the main complaint? It's just plain reflux, is regurgitation, is atypical syndromes, is pneumonia, is voice changes, cough, is strictures, ulcerations. The AGD is very important. If the patient has severe ulcerations, LAD, esophagitis. What is the degree of pre-op dysphagia? Some patients will have a lot of dysphagia from the reflux, and that's the main symptom. Now we see some patients, chest pain, atypical chest pain. The degree of this motility, and with the high resolution motility, things change. Now the definition of hypomotility or dysmotility changed, and we have to be aware of that. This slide shows that. I will go through fast. Before was the distal amplitude and the failed peristalsis. Now we have effective and ineffective peristalsis. But I think what is very important is to identify the different techniques. And I will tell the residents, a Toupet is not an open Nissen. It's a completely different operation. So it's not like we do a Nissen and we just leave it open. We don't bring it back together. So a Toupet is a much longer funduplication than the Nissen. And we also, depends on the technique of how we learn it, sometimes we attach the funduplication to the crus, coronal sutures, or even lower into the pre-aortic fascia, depending how we do the technique. So as you can see, they are completely different operations. Now, I went through all the randomized trials through the years, and we can see here, this is one of the first one. This is from Sweden, 1996, 140 patients, half and half, Nissen, Rossetti, and Toupet. Interesting, only half of the patients had the crura repair. There was no hiatal hernia repair in 50% of the patients. And it was a good follow-up, 5 years with not only scores, EGD, manometry, and pH study. You can see here on the left side, we have the pre-op LES before the operation and after. In blue is the Nissen, and in white is the Toupet. We can see that both operations increase the LES pressure. In the other graphic, we have the dysphagia. You can see the patients is between years. The patients have more dysphagia with the Nissen at the beginning, but interesting in this paper, patients with Toupet will have more dysphagia in the long term. But the conclusion is like the total failure rate was higher among patients with a Nissen, and mostly due to intrathoracic herniation. And that's usually what we see. The failure comes from the migration of the wrap. But Toupet is more physiologic, and you have less postprandial complaints, but both are equally effective, at least in this trial, to control the reflux. 97, this is the graphic I showed before. A small group of patients, 40 patients, 23 and 16 for the Nissen and Toupet. Interesting, this motility group of patients were completely excluded for this trial. And you can see that both Nissen and Toupet offer effective therapy with more than 90% satisfaction. And there was no clear advantage between one and the other. Another trial, 2016 from the UK, and this is an important trial because they will randomize patients based on the motility studies. As you can see there, how the definition of effective and ineffective motility, 64 went for Nissen, 63 for Toupet. Interesting, all these patients were done under a bushie, and I think that's important. The follow-up was with symptom questionnaires, pH, and manometry. The results are here. No significant differences in reflux-related symptoms after 1 year. Dysphasia was, of course, it was more evident in the Nissen group of 1 year, but no significant differences between groups of dysmotility. It means that dysphasia was equal in patients with bad motility or normal motility before the operation. So this paper says that, as the previous speaker said, tailoring the surgical anti-reflux operation based on the manometry should be abandoned because there's no difference. Both groups behave the same. 2007 is another paper from Belgium, 140 patients, 77 for Nissen, 3 years follow-up. But again, patients with abnormal manometry were not randomized. So again, the value of dysphagia after surgery is less because the patients were not randomized, and also all those patients underwent Toupet fundoplication. There was no follow-up testing performed, just questionnaires, which again is not very strong evidence of results. And this is the group of patients. Interesting enough, at follow-up, patients with Toupet fundoplication, they have more flatulence, nausea, and dysphagia. But both group of patients have a high level of patient satisfaction after the first year. And you can see that dysphagia and bloating are not avoided by a Toupet and are similar to the Nissen fundoplication. This is another paper from Germany, and this is a good one. I think it's one of the best because it's 200 patients. They divided between motility problems and normal motility, and then from those two groups, they again randomized between Nissen and Toupet, and they did EGD, manometry, and pH before and at 2 years. So it's a good quality data to analyze. You can see here that the dysphagia was more in the Toupet group before surgery, and also in the Nissen group who had this motility. And you can see that the patients who underwent a Nissen and have a dysmotility, the dysphagia increases slightly, as you can see in the first arrow after the operation. And on the Toupet group, they have a lot of dysphagia before, but the dysphagia improved after the operation. As you can see, pH was efficient, and it was very successful in all the groups for Toupet and Nissen. So in base of pH, controlling the reflux was very efficient. And LES pressure was similar, except in the patients with normal motility that they underwent a Toupet, the LES pressure was almost the same as before surgery. Conclusion of this trial was esophageal motility disorders does not affect clinical outcomes, so there's no required tailoring like the previous paper. And they said that Toupet is a better operation because it's equally effective treating reflux and has less postoperative dysphagia. And Toupet fundoplication reduces the rate of reoperation. And we see this in a lot of papers after all these randomized trials. The reoperation rate after Toupet is much less than Nissen fundoplication. Finishing 2010, 100 patients. This is from South Africa, but that both the Nissen and Toupet are equally effective with no difference in dysphagia. And the pre-op esophageal dysmotility has no influence in the outcome after either operation. This is from Austria, again, 125 patients randomized between Nissen and Toupet. The randomization has nothing to do with the pre-op manometry, so it was a good mix of patients. Again, the primary outcome was the improvement of quality of life. The secondary endpoints was pH and dysphasia. And the conclusion was more patients had to undergo reoperation after a Nissen fundoplication than a Toupet. Both Nissen and Toupet were equally effective in improving reflux and quality of life. And again, saying that the Toupet fundoplication should be preferred procedure due to lower incidence of postoperative dysphasia, reoperation, and other symptoms. This is, we'll go through this fast. Again, is similar results. This is a meta-analysis published last year from a Japanese Chinese group going through the 9 randomized trials that we have. And again, saying the same. There's no significant differences between Nissen and fundoplication in terms of controlling reflux, post-operative dysphasia, gas bloating, and ability to eat, to belch, are higher after the Nissen fundoplication. And the subgroup analysis did not support tailored therapy based on the manometry. So what SAGES says about this, and actually it says exactly the same. You know, the partial fundoplication is associated with less post-operative dysphagia, fewer reoperations, and similar patient satisfaction. A tailored approach to esophageal motility appears unwarranted, and surgeons may minimize post-operative dysphasia by choosing a partial fundoplication or a short total fundoplication. And again, this is very important, the way we do the operation, how we use, dividing short gastric vessels, using a bushi, and so on. But it's interesting because we find national differences and international differences. For example, at Mayo Clinic, we do mostly Nissens. I was just in a previous meeting that they are mostly doing Toupet. In Europe, most of the surgeons do more Toupet than Nissen. So there's regional differences based on the school of where we learn these operations. This is a patient that came to see us after having a Nissen fundoplication. She has a scleroderma, and she has severe regurgitation and dysphagia. You can see the Nissen there was a little bit tight. Manometry showed almost a peristalsis. So we convert this patient from a Nissen fundoplication to a Toupet fundoplication, and this is a postoperative picture, and her symptoms completely disappear. So the previous surgeon said, well, I don't care about the motility, I will do a Nissen, and it was wrong because the patient had a lot of problems. We have a second patient. This patient has dysphagia and reflux. We did the swallow. He has a sliding hiatal hernia, but the manometry showed almost a peristalsis. It was not achalasia. So for this patient, we did a Toupet fundoplication, and she did great. So in summary, except for severe hypomotility or aperistalsis, peristalsis matters less than we thought. It's important to identify the predominant symptoms and severity of reflux to choose an operation. Nissen and Toupet are both very efficient operations in controlling reflux. Toupet, we know, has less side effects than the Nissen. Again, that depends on the technique as well. Preoperative manometry, I think, is still very important, as the previous speaker said, for many reasons. And the technique and experience of the surgeon are extremely important in avoiding the post-op complications. Thank you so much.